Good afternoon, everybody, and I'm delighted to welcome you to this session. And I'm particularly delighted to be invited by the NHS Confederation, the Expo team, to chair this session. I'm Saffron Caudry, and I'm Deputy Chief Executive at NHS Providers. I think we're going to have a great conversation this afternoon. One of the key ambitions of NHS ConfedExpo is really to encourage thought-provoking discussions, challenging discussions, and to stimulate change. And I really hope we can do that this afternoon with this session and really make a contribution to that aim. We all know that communication between families, patients, and clinical teams is absolutely critical to an NHS that wants to learn and improve and is a key element of improving patient safety. And I think it's fair to say that Martha's Rule is a real moment for the NHS, and we should note that and mark that. And it's a really important step in building and improving communication and the relationship between NHS staff, patients, and their family. And delivering the best for them is surely, when we think about where we are at the moment in the middle of a general election campaign, surely thinking about what actually happens to people when they're in hospital makes that connection between what's happening nationally and what's happening locally. And that feels really important, I think, for this conversation. And I'm delighted to be joined today on the panel by Merope Mills, who's the mother of Martha Mills and has campaigned for the introduction of Martha's Rule. She's the executive editor at The Guardian and was named Campaigner of the Year at the Women of the Year Awards in 2023 last year. Aidan Fowler has got a gazillion job titles here, but I'm just going to say he's the National Director for Patient Safety at NHS England, and he's also the SRO for Managing Deterioration and Martha's Rule programme, which is important for us today. And then last but not least, we've got Helen Lidbetter, who is Associate Director of Quality and Governance at Northampton General Hospital and is a nurse with around 40 years' experience in the NHS and has been running one of the Martha's Rule pilots. So I'm going to invite Merope now to speak to us for about 15 minutes or so, and then we're going to have a conversation between ourselves and then open it up. Please do use Slido. You can access that on the NHS ConfedExpo app. Ask us your questions. We want the panel to be able to answer those questions for you. So over to you, Merope.
Thank you for having me. 25 years ago, I wrote my first piece of professional journalism for The Guardian, where I've worked for many years. At the time, I was still at university, a student of psychology at Manchester, where one of my lecturers was Professor James Reason, an expert on human error and known to most as the inventor of the Swiss cheese model. For that first Guardian article, I spoke to Reason and others about the mistakes people make at work, how human failures can cause catastrophic errors and loss of human life. Professor Reason, I knew, advised nuclear power plants, railways, and airline companies. His Swiss cheese model has also, of course, been used countless times to explain the occurrence of failures in medicine and to argue that accidents and deaths can be prevented by putting in place a series of protective barriers. Unfortunately, none of that was on my mind 2 decades later in August 2021, when I sat by my daughter Martha's side at King's College Hospital. She'd sustained an injury to her pancreas after a bike accident on our summer holiday in Wales. We'd just lived through 18 months of COVID, during which time our collective appreciation for the NHS was at an all-time high. Like others, we clapped for the healthcare staff and our system. Martha, I remember, banged a pot with a wooden spoon. My belief in and gratitude for the medical profession was unquestioned. I had complete trust in the doctors at King's who were looking after my daughter. How stupid and ashamed I felt just a few weeks later when Martha was dead after a series of catastrophic failures on the part of King's paediatric liver team. My extraordinary, talented child, who was so determined and had so much to offer, had been wiped off the face of the earth because the care for her had become careless. Losing her is a life sentence that no parent should have to bear. I won't use all my time today to go over in detail about what happened, but the story remains shocking. We'd been assured multiple times by the doctors that she would fully recover. In 20 years of treating children for that injury, no child had ever died at King's. I believe this history, along with the high status accorded to the team by the Trust, led to a level of complacency on behalf of the clinicians. A week before she died, Martha contracted an infection. We didn't worry at first. At that point, she'd been in hospital for some weeks and she'd had an infection before. But quite soon, this one felt different. It didn't go away, and she started deteriorating. We knew she was deteriorating, and she knew she was deteriorating, but the clinic team in charge of her felt sure they had everything under control. There was no one person responsible for her care, so no one spotted her trend of getting worse. For the changing consultants, who didn't bother with proper handover documentation, each day was the new normal. Despite the recommendations of the Francis Report in 2013, Martha didn't have, in any meaningful sense, a named consultant overseeing her or taking responsibility. And there was a dangerous resistance among the liver team to escalating Martha to ICU, founded according to the hospital's own serious incident report in their own sense of superiority. On Wednesday, the 25th of August, 6 days before she died, Martha started bleeding. The blood soaked through her dressings, pajamas, and bed sheets. Most people here know that heavy bleeding alongside a persistent infection is a DIC, a sign of severe sepsis. We now know that she could and should at this point have been transferred to intensive care. That's what the ward nurses thought should happen. They wrote so in their system. But no consultant looked at their system, and the nurses didn't feel empowered to speak up. So Martha stayed on the ward and she kept bleeding. She was repeatedly sick with terrible diarrhea. We worried she was getting worse, and though the doctors kept things from us and avoided the use of the word sepsis, we, in our anxiety, introduced the word, especially given that the August bank holiday was approaching. On Friday, the 27th of August, I told that day's consultant, "I'm worried she's going to go into septic shock and none of you will be here." I was reassured, it's not sepsis, it's just a normal infection. On Saturday, my husband raised his concerns again. "This is what it's like with this injury. Infections, they come and go," said that day's consultant, unengaged and uninterested in seeing Martha again that day, despite her recent DIC. By the evening, Martha couldn't stand. She was so dizzy. We told the doctors, this is new. Martha was clearly the sickest patient on the ward, but nothing changed. On Sunday, a new consultant arrived on the scene. During the morning ward round, he whispered to colleagues outside Martha's cubicle, clearly determined to keep me out of the loop, even though I was the only person with Martha the whole time. Then he left for the day on call. He didn't tell me what he knew, that Martha was clearly septic. He didn't leave a plan in case she got even worse. That afternoon, Martha had ongoing sepsis from an unknown source, very low blood pressure, a fever, and a rapid heart rate. Then she got a rash. I worried it was a sepsis rash, but the duty registrar was convinced it was something else. It sounded improbable to me, so I challenged him, but he stood firm. I still thought he was wrong, so I told a nurse, and she said, "Trust the doctors, they know what they're doing." Nobody was listening, and at 5 p.m., Martha was BPU's 8, a trigger far above the trigger to send a child to intensive care. The registrar called the duty consultant twice at home. Not only did he not come in, but that consultant said categorically that Martha shouldn't have a review from ICU, as it would only increase the mother's anxiety. In 2 ways, the failure to escalate Martha was the opposite of the hospital's own policy. Nobody came to see us after that except a nurse who was the least experienced on the ward and did nothing. I told her Martha was getting worse throughout the night, drinking copious amounts of water. The SHO failed to visit Martha once, arguing later that she didn't think it was her job to look after the really sick patients. My daughter collapsed in the morning, telling me shortly afterwards that she felt like she was unfixable. By the time she was transferred to ICU, it was far too late. She died just 4 days before her 14th birthday. The coroner ruled Martha was a preventable death. External investigators appointed by King's later told us that the negligence on the ward made them, quote, ashamed of their profession. Perhaps the most important thing to say is that had Martha's rule existed then, I'm sure I would have used it, and Martha would still be alive. You hear the phrase, lessons learned, a lot in healthcare. What you're told a lot by a hospital when things have gone terribly wrong and you've watched your child die is that lessons will be learned. The phrase is trotted out easily, but I'm not always sure it's true. I'd like people here to ask themselves honestly, are lessons always learned? And if so, how quickly does change happen? How widely? Is it in one hospital, one ward, or more? And how often does defensiveness and professional pride get in the way of trust facing up to the real truth of what happened? At King's, Senior leaders refused to accept the findings of an external report that they themselves commissioned because what it said was simply too damaging, too embarrassing, and too truthful. NHS trusts too often put reputation management above patient safety. Whistleblowers are silenced. I think if lessons really had been learned more widely in Martha's lifetime, she would still be alive. In the 2.5 decades since I was taught by Professor Reason, the airline and nuclear industry have made huge strides in safety while healthcare lags behind. I'm outside the medical world, of course, but I've spent time reflecting on why that might be. Essentially, I think it's because accidents in healthcare are quiet events that happen behind closed doors. There's no dramatic news footage, no global hand-wringing. I was determined to make sure that that didn't happen with Martha's death, which is why I chose to tell her story widely in the national press, TV and radio, and campaign for the introduction of Martha's Rule. Martha's Rule can be activated when a patient is deteriorating on a hospital ward. It means that patients and families and medical staff have 24/7 access to an urgent review from a critical care team. If it's a situation, as happened with Martha, when there's concern that a patient is getting worse and isn't being responded to adequately, there's somewhere else to turn. Martha's Rule is not a way of casting blame, and it isn't an implied criticism of treatment, but it will, I hope, do two things. Firstly, it will save lives, because sometimes patients and families constantly at bedside will be able to spot trends and notice changes that might be missed by the medical staff, perhaps because they're too busy. Secondly, it will do something to change the culture in hospitals, giving patients and their families more agencies. Most doctors, the good doctors, listen attentively and communicate effectively. They don't try to manage their patients by limiting information and think nothing of being questioned or even challenged. Unfortunately, we all know there are some that aren't like this. So Martha's Rule will do something to encourage listening and will be a step to improving culture in this way. It's about welcoming challenge so we can maintain respect for doctors' expertise but break down the deference. It will be a vital fail-safe, another barrier to protect people in the Swiss cheese model. But what distinguishes it is that this barrier, the power, is in the hands of the patient and those at their bedside. I call on everybody in the medical world to embrace Martha's Rule, and I urge everyone in this room to make it work properly, even if it isn't your favorite initiative. I read a consultant radiologist on social media the other day say, "I think the way Martha's Rule will be implemented in the majority of places will be performative," as if he and his colleagues didn't have a role in the rule's implementation, as if it wasn't his responsibility and that of all healthcare professionals to make it work for the benefit of patients. Because while Martha's Rule is about patient agency and communication, it's also about doctors' whole practice, how they behave on the ward, how they talk and listen to their patients, and the assumptions that they make about them. And yes, it's also about humility and openness. Those doctors that have dismissed Martha's Rule as a knee-jerk response called for by parents who aren't experts in the medical world are exhibiting exactly the kind of arrogance and status obsession that Martha's Rule sets out to challenge. Given medicine is ultimately a job about people and communicating with people and getting a sense of their thoughts and feelings and bodies, my own view is that humility and a willingness to listen should be about the most important thing a doctor can ever offer. I've learned enough to know that patient safety initiatives too often happen at a snail's pace. Freedom to speak up took 7 years to introduce. A national Pews Charter for children took nearly a decade for everyone to agree on. I can't imagine how many children's lives could have been saved in that time. For that reason, we're extremely pleased action has been taken to bring Martha's Rule into effect quickly, and that over 140 hospitals have now signed up to introduce the scheme this year. One of the reasons I'm here today is to recognise that achievement and the progress made so far. It shows a level of goodwill for the measure and within NHS hospitals, and that's very pleasing for us to see. We applaud every hospital that stepped forward to take part, and we're grateful to have the support of the BMA, the GMC, CQC, NMC, and of course the NHS Confederation to make this initiative a reality for patients across the UK. We look forward to working with the NHS to make this a fully national offering in years to come. I know that some clinicians remain suspicious of Martha's Rule and concerned it will be overused, despite the fact that similar schemes in hospitals around the world show this is never the case. We're also aware that many doctors will regard Martha's Rule as a tiny side issue in the context of NHS underfunding, but it can be a small, important win, one with larger cultural ramifications. Progress is never simple, And I'd like to remind everyone here there was a time, not that long ago, when the introduction of a surgical checklist was perceived as an assault on the practitioner's integrity. It's now welcomed as an important tool in reducing complications and preventing medical errors. Pushing through change requires strength and leadership, and that's what we're looking for from hospital leaders as Martha's Rule is rolled out. Already I'm contacted on a weekly basis by people thanking me for making them more confident to advocate. Some are even doctors themselves on the other side of the hospital experience for the very first time. Martha's Rule, if properly embraced, will save lives and change culture too. It gives more families the confidence to advocate for their loved ones, if it makes a number of doctors better listeners, if it prevents a handful of deaths every year, it will have proved invaluable. For those doctors who want change, for grieving parents like me who will never be the same, and for patients, not Martha, alas, but for people like Martha, so they get the treatment they deserve and they get to live their lives like you and me. Thank you.
Thank you so much for that, Merope, and both for telling Martha's story, but also telling us about Martha's Rule. I think it feels really, really important. And I think as the launch pad for our conversation this afternoon, I think it would be really good, Helen, if you could tell us about the work that you're doing in Northampton General Hospital. So you were a worry and concern pilot, and you've now been confirmed as one of the 143, and I think we should mark that, 143 trusts signed up to be taking part in Martha's Rule. Can you tell us about the work you've been doing to embed this system of raising concerns, how you've gone about it?
Yes, thank you, Saffron. Good afternoon, everybody, and it is indeed a pleasure to be here. I just want to say, first of all, that Northampton haven't got it sussed. We are not fully compliant. We have just started our journey, perhaps a little bit ahead of everybody else. We've still got a lot of work to do, and we're determined to really make it work. There is a real hunger in the organisation to get this done, but to get it done properly, and for it to be meaningful and not become one of those lovely NHS rituals that is just done. So we were very fortunate. We were selected to be one of the 7 pilot sites for the Worry and Concern project, and it fell at a particularly good time for Northampton. The patient safety team had done a huge amount of work in terms of prevention of deterioration. We have a digital system that alerts our 24/7 critical care outreach team when a patient's observations score, and also there's a nurse concern button. At the same time, there's a deteriorating patient task list that clinicians can follow just to make sure that they've got everything covered off, and that has to be done within a certain time frame. So the results were looking good in terms of our unplanned admissions to ITU and also our cardiac arrest data. However, looking at some of our incidents, we were aware of a series of incidents where some of our neurodiverse patients had not received gold standard care. And we knew that we were not listening to some of our patients. So in what I'm going to describe now, which is 2 basic projects, which were the 2 aims for the Worry and Concern project, but linked very much to components 2 and 3 of Martha's Rule, bear in mind that whilst we are doing this, we are trying to be inclusive. Our populations are vast, aren't they? And at the end of the day, it is about treating people as individuals and spending time with them and listening. That word listening comes up quite a lot. So the first project was to launch our Call for Concern project service. This isn't new, actually. When you look at the literature, it's been done in America, it's been done in Australia, and the Royal Berkshire have done this piece of work, and a number of other hospitals. So having discussed with other hospitals, we decided not to do the pilot on a couple of wards, because actually the great British public do not inundate you with a lot of calls. Okay, they're very distinct. There aren't lots of calls, and I'll give you the data in a minute. So we decided to go whole hog and launch our Call for Concern service across all our adult inpatient wards, and that's 23. We have just celebrated our first birthday, and we are looking forward to going into maternity and to paediatrics. Now, again, I was thinking, well, we'll just go into maternity first because they're used to outreach. But paediatrics and maternity in our organisation work really closely together, and they actually felt it was safer if we launch together because their services are so intertwined. So we are hoping in the next month to go into both of those areas. We are so fortunate we have two incredibly keen leads, and they are driving it forward. So just the data on our first 12 months then, we have had 81 calls. Okay, of which 21 have met criteria. So that's over a year. So average about 7 calls a month and about 2 meet criteria. And what do I mean by criteria? First of all, it has to be about deterioration. Some people will see a number and they're absolutely desperate. They can't find their hearing aid, they can't find their charging lead, and they will call it. So that's clearly not to do with deterioration. However, our lovely outreach team will signpost them to the right person to talk to. The second thing that we ask is, have you spoken to your ward team? Because the last thing we want is for outreach to come stomping onto a ward and take over. That's not great. That's not great teamwork. And the teams themselves will want that opportunity to sort that patient out. So we always say, if you're still not happy having spoken to your team, do come back to us. Every single one of those 21 patients has been stabilised by our outreach team and has not needed critical care. The second part is probably the bit that I'm worried about doing properly most, and that is the patient wellness questionnaire. So this is where, on at least a daily basis, we as healthcare professionals will ask a patient, their family, their carer, how do you think you're doing? Bradford were the team in the original 7 hospitals, the Worry and Concern project, that did the most work on that. So we used some of their questionnaires, and we did a trial on our assessment wards that was 78 beds for a month. We got a lot of questionnaires back. About half of them weren't completed properly, so that gave us a huge amount of information. We felt actually it was quite complicated. So the questions now for our second pilot are, how frequently do we need to ask that question? We desperately don't want it to become white noise. We don't want it to be part of a ritual. We don't want it to be tick box. How do you phrase that question? How are you is almost a greeting sometimes. It has to be, Aidan, you've been with us for a day now. How are you feeling compared to when you came in? Are you feeling better? Are you feeling worse, or are you feeling the same? And feeling the same isn't necessarily a good thing. So we are working on the feedback from the staff on the questionnaire, and are about to do phase 2 of that pilot, and including another medical ward, a surgical ward, and our haematology and oncology ward, because again, our data shows that there have been some instances with sickle cell care and care of cord compression that we may have picked up and acted differently if we had listened to the patients more. So that's where we are with the project so far.
Thank you so much, Helen. And before I turn to Aidan, can I just encourage you again to use Slido if you have any questions for us. It's on the ConfedExpo app, so do get your questions on there. Aidan, we heard from Helen there about what's going on in her trust. What's happening nationally to help organisations share and learn from each other? And how do we make sure that's really adopted across the NHS? Because it's the age-old thing, isn't it, that we know good things happen in little pockets, but how do we actually spread that learning?
So, I mean, the first thing to say is thank you to people who've stepped forward. So we were really keen to be ambitious in the first year, and we knew that there was critical care outreach in something like 170 sites, and it's sites, not trusts.
Yeah.
We aimed at 100 because it felt like a really good start. I knew when we had 10 people apply within the first hour that we were going to exceed that. And we've had 143 sites, and we've still got people stepping forward. So that's an amazing response. So there is enthusiasm out there. We've already had our first webinar with that group, and Helen's talked a bit about models. We don't believe there is a perfect model out there. We've got pilot sites. So we're developing this with those teams, and it's important. And of course, with modern technology, we're able to reach out to all those groups frequently and keep in touch and develop together what's going on. There are some basic principles that we know about that have been talked about, but there's an enormous amount of detail that we're working through together. So it's manifesting concerns about adult critical care teams going to see children and what can we do better in the paediatric sphere. How do we introduce this in maternity, has been mentioned, or the emergency department? There's lots of complexity and calls to professional bodies and so on to make sure we get that right. Our aim is not to enforce a model on the system, but to develop a model that makes sense to the system and best enables this to happen. And we will develop that together over time. But if there's anyone, I don't think there'll be anyone in the audience that thinks we're not going to do this. We'll all be doing it once we've got a model that we think works, and once we can then develop the ideal model, we will be doing this, and we're already looking at how would we do this in a mental health organization? How would we do this in the community? So it's coming to you, even if you haven't signed up already, be in no doubt about that, but we want to work with you to develop the perfect model.
And just to push on that bit about sharing the learning, so as we go along with this, how are we going to make sure that everyone learns from each other?
That network's really critical.
Yeah.
Because there are lots of people already doing it, but as you say, you're already saying, well, I have a concern here. So we went to Northampton, I went with Ruth May, who's in the audience today, to Northampton, and we had a really powerful story from one of their own nurses, and her husband had sepsis, and she was really reluctant to pick up the phone. And to Merope's point, you know, I would have picked up the phone if it had existed, but not everyone will. You talked about codifying. I think it's really important that we will struggle to give agency to some groups, and I can see there's a question about that we can come on to, but we need to make sure where possible we codify this. We create forcing functions so it doesn't rely on people being brave enough to pick up the phone. At the same time, we want to encourage people that it's okay to call.
Thank you. And I think that leads nicely on to my next question. And Merope, perhaps I could ask you, looking at this from the kind of the other side, really, and thinking about kind of the role of patients and families in their care and making sure that voices are heard. What do you think are the really kind of critical elements to making those changes and turning it into a reality? So it's one thing people speaking, but I think the listening piece feels really important.
Yeah, I mean, it cuts both ways, and I think I've reflected a lot about how I grew up in such a culture of deference to doctors and gratitude, and I kept trying to be respectful and say my piece, and I thought I was getting it across, but I wasn't. And so I think on the part of patients, there needs to be, respect, but less deference. I really want, my big thing is I think we need to be more equal. It's a very unequal place, a hospital ward, and there's a hierarchy, and it's very steep, and it's very strict. And, when I first started talking about that, I sort of thought the nurses were at the bottom of the hierarchy, and I refer to that because, they didn't feel the ability to speak up in Martha's case. But I've actually come to realize that the people at the bottom of the hierarchy are the patients. They are the ones with the least power. And I just would like to upend that and just have a sense of mutual respect between doctor and patient, that mutual respect and mutual listening.
Thank you. And Helen, there's a question on Slido which says, how will Martha's Rule be implemented in a culturally sensitive way or adapted for ethnic minority patients who experience additional barriers? And you talked about how the work you've done in your hospital around learning disability patients and what you'd picked up there. But what are your reflections on that in terms of kind of the listening piece and how we adapt this approach?
Absolutely. I think it comes, I'm a bit of an old-fashioned nurse, and it's actually about treating people as individuals at the end of the day. We've been liaising with some of our diverse groups, obviously the LD group and the Autistic Society, but other groups as well. And it is just recognising that not everybody finds it easy to talk to a healthcare professional. We talked about deference. Culturally, that can vary as well. Having the language Not everybody is equal on that. And there are ways and means that we can build certain systems into the way we ask a standard question, and perhaps using family and things like that to help that patient express themselves. But there are ways around it, but the core of it has to be recognising that our patients are individuals and have different ways of communicating with us. And that's part of being a nurse at the end of the day, it's part of being a healthcare worker.
Thank you. And Aidan, from your perspective, how do you think we overcome these barriers?
So it's something we've talked about all along. I mean, we've done work in the patient safety team on inequalities. We know harm is unequally experienced. And we've already started work with the Race and Health Observatory saying, and we had a roundtable recently saying, how will we make this meaningful to different groups, knowing that the concept of call for concern may not exist in some languages. There is a culture of deference in some communities where they would be very reluctant to pick up the phone. And so we're already working with them to say, look, what do we call this? How is it branded? Has to make sense to people, because the start is that if there's a leaflet that says you can call for concern, you can use Martha's Rule, it makes sense to people and they say, this is something I want to read and understand what to do in adversity. So work ongoing on that. I think it's a really important thing. And I think we will have to accept that some people probably won't ever pick up the phone, which is back to the work, for example, Bradford are doing, saying, we think if you ask the right questions of a family or a patient, you can get ahead of physiological scoring by some distance, and that's important. And then you can say, well, if you hit a score in that, then there's a requirement for staff to call for help on your behalf.
Thank you. And just something that struck me, and particularly interested in your views, Merope, on how we find that balance between everyone knowing and understanding what Martha's Rule is and it not becoming the white noise that Helen spoke about. So I wonder if you've got any thoughts around that.
So I think being very clear at the point of admission and the nurses communicating, that the nurse is such a big piece of, the care. They're the people you see every day. And I think when Call for Concern was initially introduced, the nurses there told me that they would sort of press the number into the hands of the patients and say, this is what it's for. It's not for this, but it is for this. It's not if you've lost your hearing aid, but it is if you think you're getting worse and if you're in trouble. And just having that direct conversation, somebody saying that to you, this is your emergency number. This is what you call if you think you're not being heard. Anything else? Call us on this button. Come and get, but just being absolutely clear and communicating all the time. This is the purpose of this. Not just ignoring it, not pretending it's not there, not doing it performatively, but being honest and treating people as if they aren't stupid and they aren't going to overuse it if you tell them what it's for. People, that the respect and the gratitude people feel in hospital is enormous, and the goodwill is there if you treat people likewise. Please may I answer a question which is there as well?
Yes, of course.
It's just somebody says the principle of Martha's Rule challenging doctors' decisions could equally be applied to primary care. How do you think you could implement it there? This isn't my expertise at all, but it would be wrong of me not to mention that I've been contacted by another mother who, as some of you may know, her daughter who was in her 20s contacted her GP over 20 times in 3 months. And was dismissed. Part of that was during COVID, and I think that was some of the problems. But by the time they actually saw and believed her, she was moved to hospital and she had 3 weeks left to live and she had cancer. And, it was dismissed as women's pains, making it up. And the mother of this girl, her name was Jess, has come up with an equivalent thing called Jess's Law, where she says people who contact a GP about the same thing 3 times should be automatically escalated. I'm sure there are benefits and negatives to that, but I just want to mention it because it seems like a very similar story.
Yeah, it's really helpful. And actually, I was going to ask you, Aidan, that question around primary care, because you talked about rollout to other sectors beyond acute. What's the plan for that?
So there's parallel stream of work. So we've got a big program to introduce the first part. We've then got to think about those who don't have critical care outreach and how we introduce that across the system. We've got to think about mental health, as I said, community and so on, and primary care. And to the Jess's Law, we're already in discussion with our primary care colleagues about that and the concept of, I'm slightly worried, I have to say, about a number 3. What's magical about that? What if you're worried after 2, etc. So, you know, but there is an important point about what is the solution to that issue of we kept going back and we weren't being heard, and how do we escalate that? And we're already in discussion about that. And so there will be parallel work to think about, well, what next? While we're doing this, we don't want to get to the end, breathe a sigh of relief and say, now we have to start elsewhere. We want to be doing that as a parallel program to look at other sectors and how it works, because there won't be critical care outreach in primary care, so it's a different approach required.
Thank you, thank you. I just want to ask a question of you, Helen, which is about how you've involved clinicians in this process, because obviously that's absolutely critical, isn't it? Taking clinical staff, doctors with you on this. How's that worked?
Yes, I saw that question came up, so thank you. Absolutely, I cannot stress how, for instance, comms is your best friend. You've got a huge amount of work to do to educate your parents, patients, as Merope has said, but also your clinical staff. And we used every opportunity we possibly could to talk with staff face-to-face, but use every platform that we could possibly think of, including things like social media, etc. I work very closely with our Deputy Medical Director, who has patient safety through his core, and absolutely supports me in terms of communicating to particularly the doctors. The first thing was to listen to their concerns. So the top concern was, will this mean more work? And that's a real worry at the end of the day. Everybody is working over and above anyway. And the second one is, how will it affect me if I then have somebody else coming to review my patient? And this is about the change of culture that has been, I think, a thread through this conference, really, that this isn't supposed to be, naughty doctor. This is actually having fresh eyes on a situation. This is about listening to patients and to carers. And this is another layer of information that helps in clinical decision making. And actually, this has got to be supportive, and it's got to be team. So, and that's how we've sold it. People have had to use it. They know that they're always included, so if outreach comes, there is communication with that team, there's clear messages in the notes, those clinicians are informed and involved. So it's not about stamping all over people, it is just that extra layer of safety that's going in.
Thank you so much. Sadly, we are nearing the end of this session, but for each of you, I'd just like to ask you, we've got an audience of senior healthcare leaders in the room. What's the one thing you want them to do as a result of this session and what we very powerfully heard today? Aidan?
So I'd obviously say embrace this work. Please don't fight it. It's for your patient's benefit. A friend bought me a book recently about a Swedish guy who went off and became a forest monk. And I'm only halfway through. I assume the message to me was I need to chill a bit. But anyway, there is a question in it that I think is really important, which is, what if I'm wrong? And this is at the core. There are two things at the core of this, which is be curious, and secondly, don't obsess over it, but think sometimes, what if I'm wrong? It's a really important question for us as clinicians to ask ourselves. It's that humility bit of, this is helping you. This is there for your benefit. We heard from Amy Edmondson yesterday about her work with cardiac surgeons who learnt that people challenging them was a supportive thing for them, not a problem, but they had to learn it. Let's learn that faster.
Thank you. Helen?
I think I'm just going to repeat what I've already said. It's partly about changing culture, but it's also just giving staff the time to do this absolutely properly. Particularly the patient wellness questionnaire question is the thing that I think we've got to hold on to.
Thank you. Merope?
I'm going to go back to that social media doctor who said this is only going to be implemented performatively. So if you are a senior leader here, and I would say don't implement it performatively, implement it meaningfully. And if you're senior, go around to the wards and ask people, have you heard of this? Do you know what to do? Do you know what it's for? Like I said, you know, if you have this small problem, do this, but this is available to you if you have this. Like, actually make sure that it's being trickled down, that patients know about it, and it's not just a thing that you're doing to tick box to say you've got Martha's Rule, but you actually haven't.
Thank you so much. And I think, you know, I said at the beginning that this is a moment, isn't it? Martha's Rule is a moment to change things and push things forward. And I just want to thank all the panelists, but particularly to thank you, Merope, for telling Martha's story and your story and enabling the NHS to make this change. So thank you very much.
Thank you.